Jonathan Youssef, Networking for Your Optimal Health. Today's topic is going to be about antibiotics. With me are two students, a South University student, PA, and a LECOM student who are going to help me in my antibiotics lecture. So I might be asking them a few questions, and so any participation they have will be great, but the goal is to get through this lecture a couple of times. So in other words, you guys should be reviewing this lecture, listening to it a few times to catch everything, because there's going to be a lot of information. Antibiotics are there's a huge amount of antibiotics out there, and each antibiotic needs specialized attention. So let's start our antibiotics lecture. There is two categories that we really have to consider. We have to consider gram positives and gram negatives. Okay, so I'm going to start off with the bacteria, right? Because bacteria, the goal of the antibiotics is to kill off the bacteria. So we need to figure out which organisms we need to focus on. So gram positive, what is and I'm going to ask my students, what is the one gram positive cocci that we are really worried about in the hospital setting, that we're getting a lot of resistance to?
Staph.
Correct, staph. So in addition, it's not just staph, but a very high potent staph that is becoming resistant. What's that one called?
Mrsa.
Mrsa, okay. Mrsa stands for Methicillin-Resistant Staph Aureus. What is a second bacteria that is very common that goes along with staph?
Strep.
Correct, strep. And there are several kinds of strep, right? There's strep pyogenes, there's strep pneumonia, there is strep aggluticans, I believe. So there's several types of strep that you have to consider. There's group A and group B. Now, I always look at this as group A on top and group B on the bottom. So when you're pregnant, what organism are you looking for? What test are you doing for the vaginal?
Group B.
Correct. Group B, beta hemolytic strep. What is strep pyogenes? Group A or group B? Strep throat.
A.
Correct, which is strep pyogenes. So keep those in mind. Next, we're going to be talking about gram-negative organisms. So for my medical students, what are some of the bigger named rods, gram-negative rods that we have to consider?
E. coli.
E. coli. Okay, where is that found mostly? In the
GI.
GI as well as in the urinary tract, correct. And so urinary tract and GI for my students. And what is the big one in the hospital setting?
Pseudomonas.
Correct. Pseudomonas aerugosum. So basically, Pseudomonas is one of the biggest organisms that we have to be concerned about in hospital-acquired infections. Why do I put this in the middle? Because before the advent of antibiotics, we wanted to get organisms that are gram-positives and gram-negatives. The first antibiotic that we are going to be using that's going to cover both gram-positives and gram-negatives, the one that came out on the market is Penicillin. All right, so penicillin will cover both gram-positive and gram-negative, but is it strong? Not really. We've seen resistance against penicillin. So, you know, there are antibiotics like amoxicillin that seem to be a little bit more powerful, and then there's ampicillin, which can also be used in IV and is used a lot for prophylactic treatments before surgery. So there's a lot of uses of these two organisms. I'm sorry, not organisms, these two antibiotics. Penicillin also has one particular name because it comes from the Mrsa. What does this one stand for?
Methicillin.
Methicillin, correct. Methicillin. So in regards to the methicillin, when something is resistant to this, and do we use this much in the oral route in the outpatient setting? We're not using a lot of methicillin. We are using amoxicillin, we're using PenVK, so we're not using methicillin. The only reason we're using methicillin is in the laboratory setting. The laboratory setting is to determine if the staph is resistant or not. So the methicillin is rarely used. It's only used in the laboratory setting to make sure that it's not Mrsa. Now, the reason why that's very important is that because you don't want to use simple antibiotics like penicillin for a Mrsa infection. Which antibiotic do we use for Mrsa? Correct, vancomycin. Now, we were just talking about a new antibiotic for those who cannot tolerate vancomycin, which is Linezolid. Very good. I believe that's spelled correctly, but we probably will make some adjustments if that's not. So, the reason why the board question is going to ask you which antibiotic you're going to be using for Mrsa. It's probably going to be Vanco. They're probably not going to ask you for this antibiotic. The problem with Vanco is that usually it's in IV form, although there is some oral form, but it can have ototoxicity and nephrotoxicity. And for those who cannot tolerate it, there may be another option. And also, there's been some resistance to Vanco as well. So that's where that comes from. Let us look at the gram negatives. So now you have a patient in the hospital setting, right? Who, or maybe let's go with the outpatient setting first. And you want to get both gram positives and gram negatives at with a stronger antibiotic. So you use an amoxicillin combination. What is the second agent that can cover both gram positives and gram negatives and is more powerful than just straight amoxicillin? Augmentin, which is amoxicillin with a beta lactam, which is clavulanic acid. Okay, so that is the all-powerful antibiotic to get, be a step up from your penicillin family. Secondarily to that, but this is not going to cover Pseudomonas, right? So now we're looking at the hospital setting. We want to use IV antibiotic. What antibiotics are we using in the hospital set to cover, which is similar to a beta-lactam with a penicillin? Pip? Tazo. Correct. Penicillin with the addition of a beta-lactam. And so that is where you're getting both gram positives and gram negatives. Correct? So now you're covering these gram-negative hospital-acquired bacteria and organisms. So in this particular setting, that's where you want to start with your penicillins, okay? When you're looking at cephalosporins, there is a nice little chart that I like to use, and it's basically, again, starts with gram positives and goes all the way to gram negatives, and it covers the cephalosporin family. The cephalosporin family are 4, let's just call them 4, even though there's 5. There's 4 generations, correct? And the first generation, like let's say Keflex, for example, Ceftriaxone, is in the first generation. It covers more. So cephalosporins go from first generation to fourth generation. The first generation covers more gram positives, correct? And then the fourth generation covers more
gram negatives.
So the way it works is this. You start off the graph at very high level, and then as you go to your second, third generation, less and less coverage. Fourth generation, very little coverage. And this opposite is true. Gram negative coverage in the first generation is weak, and then as you hit the fourth generation, it's a lot higher. Why do I say that is, where do we have in our office we use Rocephin a lot, which is Ceftriaxone. Which generation is that?
3.
Correct. Third generation cephalosporin. So it's covering many of the organisms, gram positives and gram negatives, as well as, you can still use some, second generations with safety. Which generation is closest to penicillins in terms of allergic reaction?
1.
Correct. First generations like Keflex are linked closer to penicillin. So if somebody's very allergic to penicillin, they may be very allergic to Cathlex. So you want to use a third generation cephalosporin for those who are allergic to penicillin, and also cover more organisms, so something to consider. Now, another class is quinolones. Let's start with a first generation quinolone. What would be a first generation quinolone? Ofloxacin, for example. All right? Ofloxacin, the best thing about it is it's a new antibiotic. It covered a lot of gastrointestinal issues as well as urinary issues as well as respiratory. However, you take it often. It was a bit more toxic, so we needed to go as second generation. What is second generation?
Cipro?
Correct, ciprofloxacin, second generation Cipro. So then, what is our second generation cephalosporins, which is a little bit stronger? Give me an example.
Cipro?
Correct, Cipro. Now, Cipro is great for gastrointestinal and urinary. There's been some theories that it may not work so well on the upper respiratory, so that's why a third generation cephalosporin came around, which is levofloxacin, correct. So the fourth generation really is a great generation. It covers both upper and lower, and there's a couple of them on the market. One of them is moxifloxacin. So moxifloxacin also, there's another one called Factive, which is difficult to get, but it is very effective. So you have a few options when it comes to fourth generation cephalosporin. So now we're going to go into some disease processes. Let's talk about community-acquired pneumonia, okay? So this is pneumonia that's found not in the hospital, but just community-acquired pneumonia. What organisms are we going to be concerned about? Strep. So we got gram-positives.
H-flu.
H-flu, which is a gram-negative. So strep, H-flu, so you have gram-positives, gram-negatives. Okay, but when community-acquired pneumonia, let's talk about mycoplasma. Is that a gram-positive or gram-negative? Correct, it's atypical. So now what we want to do is we want to get gram-positive, gram-negative. Okay, so which organisms can we use? Can we use augmentin? Sure, we can use augmentin. We can use piptazo, we can use penicillin, gram-positive, gram-negative. But where about my atypicals?
Azithromycin.
What's that?
Azithromycin.
Azithromycin, what category of medication is that? These are?
Macrolides.
Macrolides, correct. So now we're getting into a macrolide. So some people, like in our office, we will go with Zithromax or Viaxin and just cover all of the gram-positive, gram-negative atypicals in one. So by using macrolides, right? Because they won't cover. What other antibiotics cover macrolides? I'll give you a hint.
Quinolones.
They will also cover it too. So you could do a quinolone. Now, I don't go with quinolones for one main reason. Initially, it's because of one side effect, tendon rupture. I've had a couple of patients who have had issues with their tendons, aches and pains. So quinolones I do save for my COPD patients who have pneumonia as well and who can't tolerate the macrolides. One of the things about macrolides, a very common issue is that you'll have many patients on statins, and statins and macrolides have to interact a little bit. And in some cases, I usually hold the statin while they're on this macrolide. So keep that in mind. I do it very often. And if you don't hear it from your doctor's office, you might hear it from the pharmacy. They'll call the doctor and let him know because there's an interaction. It really can cause the statin to worsen. In other words, cause you myalgia or affect your liver. So one of the things that you might need to keep an eye on. So what if it was hospital-acquired pneumonia? Okay, so now you're in the hospital and now you have pneumonia. What are you concerned about, right? We've got our gram-positives, right? Gram-negatives, but we all know that there are some gram-positives that are resistant. So what do we do? What do we have to cover? We have to make sure we cover Mrsa. So what do we want to give? IV.
Bank.
Yes. All right. So Vanco, you want to give plus or minus, right? What do you want? What other options can you give? Can you give a macrolide? You could. Macrolide. Can you give a cephalosporin?
Yes.
Yeah. You can give a cephalosporin. If you do the cephalosporin, you might still need a macrolide because it gives gram positives, gram negatives. So you got Vanco Mrsa only, right? Not the rest of the stuff. You got the cephalosporin to cover the gram positive, gram negative. You got a macrolide to tip the atypical. Have you ever seen that happen in the hospital? They come in, we don't know what's going on with them. They're septic. They think it's respiratory. They were just in the hospital. We think it's Pseudomonas. We think that there's, Mrsa. So we throw the whole gambit until we can figure out what's going on with them. And then once we have the organisms, we can narrow it down. So you'll see that a lot, this combination anytime of hospital-acquired pneumonia or cellulitis or urinary tract or sepsis. You may see this combination being used just to cover everything. Now for urinary tract, they may not do the macrolides, okay? They may just do this and this. So there are many antibiotics to use, and what you have to do is understand that you want to cover gram positives, gram negatives, figure out if you're in the hospital setting or outpatient setting, narrow it down to what is the least, the antibiotic that has the least side effects and the most cost effective for you to get the maximum results. So you can do penicillins or augmentin in an outpatient setting, macrolides for upper respiratory bronchial infections, pneumonias. And then you want to advance to either cephalosporins, and in the hospital setting, you want to look at vancomycin, piptazo to cover both gram positives and gram negatives. One of the things that I forgot to mention was you can put piptazo and the third generation cephalosporin almost in the same category because they're going to cover both gram positive, gram negatives. And then you've got a really like a home run hitter here in the Quinolone family where it can cover all of the organisms, but they do have some side effects. So understand your bacteria and you'll understand your antibiotics.